complexity, although we were always seeing this in our ICUs. Being an ICU man, what I would say is that no matter what, whether it's a rheumatological disorder or a oncological disorder, or hematological, or sepsis, or dengue, or whatever, be the initiating factor in these patients in our ICUs when they get specialists. So it's a great honor being a part.
Sir, your voice is breaking up.
This conference. Okay, I'll try and be louder. And so, let me introduce the next speaker. He's a professor at Leeds Institute of Rheumatic Musculoskeletal Medicine, University of Leeds. In a clinical research, he has used microanatomy and imaging to elucidate the pathogenesis of seronegative inflammatory diseases and has defined the central role of anthesis in joint pathology in several key publications, including the cytokine-mediated enthesitis theory of synovitis, in the seronegative spondyloarthritis, diseases that include ankylosing spondylitis and psoriatic arthritis, in Lancet in 1998. He runs clinical auto-inflammatory network with Stenisa Savic, and he has developed the modern immunological continuum classification of inflammation against self-loss medicine 2006. His group have shown how COVID-19 immunopathology is distinct pulmonary pathology that differs from classic mass and DIC. Again, published in the best journals. His group has defined normal human anthesis in and adaptive immunity, including gamma delta T cells and conventional T cells in human anthesis. Dennis is section head of experimental rheumatology at Leeds Institute of Rheumatology and Musculoskeletal Diseases. He has served on the editorial boards of Arthritis and Rheumatism and Annals of Rheumatic Diseases, and has served as a member of the Scientific Committee of the European League Against Rheumatism, and is co-chair of the EULAR task force, and has so many more international prizes that he has won. So over to you, Dennis.
Thank you, Christian. Can you all hear me? Yep.
Yes, we can hear you well. We can hear you well.
Yes. Sound wasn't great there when Christian was introducing. Thank you, everyone. Thanks for asking me to speak. Moving towards precision medicine, role of cytokine profiling. And I'll talk about moving towards precision medicine, but as you will see, I'm not sure about the exact role of cytokine profiling. A lot of potential conflicts. I work with some companies that are in the auto-inflammatory space. So I'll talk about cytokine hyperactivation, hyperinflammation, cytokine storm, whatever you wish to call it. I will be discussing how the COVID-19 pandemic has provided a springboard, and everyone's really interested in this now. And I'll be talking about the immune cartography, as we call it, of cytokine storm. And I will basically be setting the scene for, you Indian physicians around your approach to viral hemorrhagic fever. Is there anything in my talk that might be useful, basically? So at the start of the pandemic, if I can bring you back 2 years, it's all melded into one long year because there's no travel. But at the start of the pandemic, we had papers talking about a cytokine storm. And indeed, here we have patients with like this is 10,000 picograms per mil. The levels of IL-6 were so high that it had to be expressed in nanograms per mil. It was so high. And another interesting thing about the coronavirus pandemic is that people don't die quickly. They take 2 or 3 weeks to die. And this gives physicians a lots of opportunities to use drugs. This may not happen for other illnesses where the infection can rapidly progress. So, and the other thing about the coronavirus pandemic, the coronavirus SARS-CoV-2 isn't particularly destructive in the lungs. It does lead to ARDS eventually, but it doesn't lead to lots of lung destruction. And this cytokine storm analogy caught on very quickly. And here's a paper showing that everyone treated with tocilizumab in China, in this PNAS paper, everyone got better. But in this paper, the levels of IL-6 had come down from over 10,000 picograms per mil to a more modest 153 picograms per mil on average. So the first thing I'm making the point is measuring cytokines, what does it tell us? And of course, many features of the severe coronavirus COVID-19 disease with multi-organ inflammation are not dissimilar to the hypercytokinemia and activation you see in classical macrophage activation or in CAR T-cell therapy, particularly CD19, anti-CD19 therapy for lymphoma disease. You see this multi-organ inflammation and coagulopathy. So at first level, all of these things look very similar. And yes, there did seem to be a logic for a full steam ahead approach with cytokine blockade in severe coronavirus disease. But when you look, as the last speaker mentioned, in classic macrophage activation and CAR T-cell therapy, the levels of interleukin-6 are really very high. And ferritin, hyperferritinemia is very characteristic of cytokine storms associated with MAS. And this is a CAR T-cell therapy cytokine storm. And the most severe disease have ferritin levels in the range of 100,000. So you rarely see this in COVID-19, 1/100th of the level on average, I would say. And so does the COVID-19 hyperinflammatory disease, which we treat with steroids and tocilizumab, is it really a cytokine storm? And here's a paper from China, which is highly cited. And if you look at the mean values of IL-6, they're actually 11 picograms per mil. And now, as we're well into this entity, we see that even people with normal CRPs and not particularly high ferritin seem to be responding to therapies. So the whole idea of the classical cytokine storm and the original papers and claims that were being made around a cytokine storm with this virus are, you see the evidence, I'm not so sure. So what about the COVID-19 pathology? And the key point I'm making here is that when you're looking at using cytokine antagonism in other viral diseases such as dengue fever, which is obviously a big problem for you in India, unlike the UK here. So you need to take a look and go right down to the very basis of pathology. And I'm just going backwards, excuse that. So obviously COVID-19 causes an alveolitis. So it's right in the alveolar territory. This is from my friend and collaborator, Lucas Catercio, in the north of Italy, who sent me this picture at the start of the pandemic. And you see it's very much a ground glass alveolitis without tissue destruction. And basically the pathology of the pneumonia is played out in the alveolar territory, which is up to 500 million alveoli, which covers the same area as a badminton court. And obviously some of the best badminton players in the world are Indian. So this is where the pathology is played out primarily, and I'll be talking about this. So this CT scan shows somebody going for surgery for lung cancer, and they have a pleural effusion linked to the lung cancer. And on the morning of surgery, they have a staging CT, and they're asymptomatic, and it shows ground glass changes of COVID, asymptomatic. And when the histology was done on this incidental COVID infection, the predominant abnormality that was evident was this is a case report, there's two of these. The predominant abnormality is macrophage infiltration of the alveoli in this pneumonia. So there is macrophage activation, but it's in the alveolus. And this is the battleground state in this pneumonic process. The alveolar type 1 interferon response initially doesn't control the infection, and then this leads to local immune activation. Now, in flu, which can be rapidly fatal, 3 or 4 days, and hemorrhagic necrosis and destruction of the trachea. Here is the severe broncho pneumonia. It's bronchial. Here's the cartilage in the trachea. Lots of vascular thrombosis in large vessels and tissue destruction and dehiscence, and steroids don't work. So that's fatal flu. But the distribution of the coronavirus infection is in the alveoli, and the alveoli are closely juxtaposed to thin-walled blood vessels. And this sets up the scenario for the thrombosis. So we pointed out at the beginning of the pandemic that this alveolar-centric territory is leading to a diffuse immunothrombosis because the ACE2 expressing cells are very close to the vasculature. So the vascular pathology is immunothrombosis, and it's very extensive. And this is generally different from flu on the right, which often has a bronchopneumonia. Now, there is lots of like immune cells at these sites of vascular thrombosis because the immune cells are moving out of the vessels into the alveolar network. And this was originally called a viral endothelitis. The supposition was that there was primary endothelial infection. Now, this extensive thrombosis involving thin-walled vessels is associated macroscopically with pulmonary tissue infarction and lots of necrotic tissue in the lungs. And here we have loss of tissue architecture and frank thrombosis of pulmonary arteriolar and venular circulations. This is a paper from Fox from the USA, again showing this thrombosis involving these relatively large vessels. As I say, these are thin-walled vessels, so they are getting caught up in the immunothrombotic process. So we made the point that, hang on, all of this vascular thrombosis, which is key to prognosis, is a physiological immunothrombosis to try and contain the viral infection to the lungs. Now, one of the interesting things is when you treat critically ill patients with anticoagulants, they actually do slightly worse. And that's because you are stopping a thrombotic process that is designed to keep the virus in the lungs and not in your cerebral cortex or your kidneys, for example. Now, of course, in milder non-critical COVID-19, anticoagulation may have a benefit. And this may be because it's beneficial in obese patients who are not able to tolerate the diffuse immunothrombosis, but this hasn't been formally resolved. Now, you heard in the last talk, which is rather beautiful, that how DIC is a feature of macrophage activation. And the original work said DIC was a feature of the coronavirus disease. And we pointed out that in the coronavirus pneumonic process, we called this a pulmonary intravascular coagulopathy, and we highlighted it amongst other things that the fibrinogen levels are high and not low. And although the FDPs and D-dimers are increased, other factors such as platelets may be normal. So it's basically a completely different pathology that's emanating from the lung. Now, in DIC, which I'm not going to go into, you have systemic macrophage activation and hemophagocytosis. Now, in this lung pathology, you get a rupture of the capillaries and arterioles and blood cells, extravasation of red cells into the lungs, and some of these are carried off to the regional lymph nodes. And you will see hemophagocytosis in the lung tissue, but this is extravascular at sites of tissue injury. It's like a bruise. It has nothing to do with DIC. It's completely different pathology. Now, don't get me wrong, in severe COVID, in the pre-terminal stages, some people can progress to a DIC. That does occur, but what I'm talking about is most people with disease. Now, a critical thing in this pandemic has been the idea that there's a infection of the endothelium driving the disease. But there's many papers now showing that there's lack of productive viral infection of endothelial cells. So of course, the virus can get taken up and get into endothelial cells, and you can see that on the EM, for example, but it's not replicating here. So here we have these vero cells, which are very susceptible to infection, and there's like up to 100 million viral particles being shed. But in human endothelial cells, there's very, very low levels of viral particles recovered. So there's very little evidence of productive infection. So the reason I'm highlighting that is you guys are dealing with viral hemorrhagic fevers and dengue. And there may be an issue around what the dengue virus could be doing in the endothelium. But I would say that productive viral infection of endothelium being treated with immunosuppression, as I wrongly have done once or twice in retinitis, which we thought was immune driven, and we give the patients steroids, and it turned out they had CMV, and the retinitis, the endothelial infection, quickly gets worse. So the fact that steroids are not harming these patients is certainly very much supports the idea that they don't have a primary endothelial infection. So again, we highlighted this near the start of the pandemic, that there's at least 8 mechanisms where you could have lots of endothelopathy or endothelial activation and immunothrombosis that are a mechanism to contain infection rather than an active viral endothelitis. Now, another thing that's very important to highlight from this pandemic is that the patients with the worst outcome, group 1 here, the ones who die the most, these are the ones with the highest IL-6 levels, but also detectable viral RNA in the bloodstream. So again, this has not really been teased out properly, but the feeling is that immunosuppression in people with RNA in the circulation may not be such a good thing, whereas people with lower CRPs, i.e. not cytokine storms, without that destruction of the alveolar network and less viral circulation or viral debris circulation, may do better. Again, this is not completely resolved because people have not been systematically measuring the RNA-emia. So basically, a PCR evidence of viral debris. There is some papers showing viral particles occasionally in the circulation, but not many. So we've highlighted this recently in one of the Lancet rheumatology article, talking about the therapeutic implications of ongoing viral replication. And so you guys are obviously gearing up towards treating dengue and viral hemorrhagic fevers with immunosuppression. But we're just making the point here is that, hang on, there may be some people where the virus is not clearing after 10 or 7 days in coronavirus disease, and maybe you want to be rather careful in jumping in with immunosuppression. And we've highlighted this here, that if you have lots of immunothrombosis and the virus is not replicating, then immunosuppression could be very good. Whereas if you have lots of viral replication and RNA-emia, maybe immunosuppression isn't so good. And as I say, this is an open question. So just putting the COVID-19 hyperinflammation in context, 15 years ago, Michael McDermott and myself devised this classification of inflammation against self from innate immune to autoimmune, or autoinflammatory to autoimmune. And we and others, grad 2 in France, have said, oh, you can actually put gain and loss of function like immunodeficiency states with loss of function, and then states with gain of immune function like familial Mediterranean fever or TRAPS. And you can also put these into this classification. Now, if you look at children with primary HLH or peripheronopathies, at the end of the day, the inability to kill CMV, EBV, and typically herpes virus drives gamma interferon. And this drives a macrophage activation. But of course, in adult on pediatric Still's disease, And the last talker, right, the speech nicely pointed out that some mass phenotypes in kids do have associated immunodeficiency, but there's many of these kids that have no evidence for immunodeficiency, particularly monophasic Still's disease. So what we highlighted here is gain of function in the immune system, or engineered gain of function, will drive excessive gamma interferon, and this will give the same phenotype. But of course, the therapy is very different. In this group, you have to treat the immunodeficiency and go towards a bone marrow transplant. Otherwise, you could kill the patient quickly. Where in this other group on the right, you can treat them with immunosuppression. So the cytokine storms are completely different. And this is something Ram and myself and Charlie Bridgewood published in Nature Reviews recently. So to highlight, when you're looking at the COVID-19, the issue is, or other viral diseases, that there may be an immunoparesis with reactive increase in innate immune cytokines giving hypercytokinemia or relative increase in cytokines and a pulmonary specific macrophage activation, completely different from mass and cytokine storm. And we published this article at the beginning of the pandemic, and we're saying these things at the stage when everyone was saying, let's give steroids and tocilizumab. And we said, maybe that these things could be detrimental and they could actually do harm. And of course, the recovery studies showed that in some group, steroids actually did do harm. And when you look at the meta-analysis of all the RCTs of tocilizumab and coronavirus disease, as you can see, many of these studies were completely negative, particularly the blinded RCTs. The biggest platform study, recovery, was positive, but it's not completely blinded. So the benefit of cytokine suppression overall has been rather incremental, like an absolute reduction in mortality, or a 3 to 4 percentage point reduction in mortality, not the spectacular reductions you see in mortality when you use tocilizumab for a CAR T cell therapy cytokine storm. So I talked about the loss of function in the cytokine dysregulation in COVID-19. So we also made the point that if you quickly could control the virus and kill it, and you had an immune hypersensitivity reaction, you could get gain of function in the system with COVID, which we think occurs in mass, in SJIA, and adult stills, and with CAR T cell therapy. So if you quickly control the virus, you might have another scenario. And indeed, this scenario came along in COVID under the umbrella term of MIS-C, this multi-system inflammatory syndrome, which can manifest, amongst other things, with a Kawasaki-like disease. And I refer you to the wonderful talk I just heard, mentioning how a mass-type phenotype can be a part of Kawasaki. So we highlighted this, that the CAR T cell therapy and the toxicity in MIS-C are not dissimilar. And in these kids, you don't usually recover the virus from the throat because it's rapidly controlled, and the children may be antibody positive and they don't usually get a viral pneumonitis. So this is more a gain of function scenario where there's no recoverable virus. So again, if you're treating a hemorrhagic fever with cytokine blockade, you probably want to be targeting those patients where the virus is already under control or cleared. This is the clear message that I seem to be getting from this. Now, with respect to the coronavirus, many of us are rheumatologists. There's this issue that vasculitis occurs in the lungs. And here are nice examples of vasculitic inflammation in the pulmonary arterial tree, lots of vasculitic inflammation. But one of our fellows, we've written an article on this, and what's happening, everyone, is we think that all of this inflammation spilling out into the interstitium basically captures these thin-walled blood vessels, which are infiltrated by inflammatory cells. So it looks like vasculitis, but it's not. Now, here is COVID tos, which children get, and these children don't usually have pneumonia. They're otherwise well. And this has been looked at by Cynthia Magro and others. And what it's nicely showing is that these kids get a cutaneous lymphocytic vasculitis, with this lots of interferon protein expression. This is MX1. So this is a type of immune gain of function to the viral infection, where there's an overreaction to control the virus, and this leads to this type of vasculitis. So again, virus is nowhere to be seen, but the immune response to the virus drives this scenario. Now, there is another scenario that critically ill patients in ICU get, and these people get immunothrombosis in the arteriole and venous tissue in the skin, and it's posse-immune, and there may be complement activation due to ischemia. And we proposed in another paper last year that some of this is a novel immunothrombosis due to clots escaping from the pulmonary venular territory and going systemic. And this is not completely proven, but there are many case reports showing large thrombi in the pulmonary venous side now. So to put it in the context of COVID, you have a viral infection largely confined to the respiratory tract and alveolus. And on the other side of the equation, you have the immunothrombosis in the vascular tree trying to keep that in the lung. Now, this is completely different to dengue hemorrhagic fever, where, as you guys know much better than me, you have a nasty pathogen that has hitched a ride on circulating myeloid cells. And this is completely different. So I would not deduct too much about the benefits or other ways of therapy with immunosuppression to SARS-CoV-2, to viral hemorrhagic fever. So just to finish up in the last few minutes, so Ram, myself, and Charlie devised an immune cartography for MAS in the COVID era. So of course, MAS has this unique feature that the macrophages that are eating the erythrocytes are doing so in the hepatoid sinusoids, spleen sinusoids, and bone marrow sinusoids. So the macrophages are pulling otherwise normal red cells out of the circulation. So that's what happens in classic MAS, and that's why you get hepatosplenomegaly and lymph nodes. And this is a pretty unique feature. And of course, you know the cytokines are familiar with gamma interferon appears to be a very big player in this scenario. And empirically, we know that anti-IL-1 therapy works. Now, rather than telling you about measuring individual cytokines and precision medicine, I personally don't think it's possible. I know there are papers in the literature showing the value of combining IL-18 and maybe gamma interferon to help identify SJIAs that are more prone to get MAS. I think more work is needed. But in this paper, we just highlighted that in different settings in vivo, in animal models and in humans, you can drive a MAS phenotype with individual cytokines, including type 1 interferons, or even feeding Toll9 agonists will drive type 1 interferon. And all of these give a MAS phenotype. So there are many ways to get MAS, and even overactivity of IL-4, the archetypal good guy M2 cytokine, macrophage 2 phenotype, experimentally can drive hemophagocytosis. And IL-10 appears to be a cytokine that tries to smooth this over and switch it down or reduce it. But as I say, this is a complex area, and it's a bit of a mystery to me why targeting one cytokine like IL-1 and SJIA particularly, or IL-6 in the CAR T cell therapy is so beneficial, because it looks like there's many ways to arrive at this. Now, in cytokine storm scenarios, a capillary leak syndrome due to endothelial integrity, breakdown, and extravasation of albumin and other molecules into the tissue can play a big role, but sometimes this can dominate the cytokine storm picture. Also, I just want to highlight that this MODS, multi-organ dysfunction, when patients are septic or when you feed them too much toll agonist, they can get multi-system disease and immune activation, which is completely different to the MAS phenotype I've just been showing you, or the capillary leak syndrome. And it should not be labeled under the same umbrella. And I know RAM doesn't like this SIRS or MODS definitions. They're not very helpful. They're not addressing underlying pathology. And again, particularly for this audience, what happens if the cytokine storm is actually due to viral activation of circulating myeloid cells. And then these macrophages will produce tissue factor, and then this will kick off an intravascular pathology, and it will lead to a picture which looks like disseminated intravascular coagulation superficially, but it's very different as the pathology may be being carried around the blood in the circulation. And of course, we know that when coagulation is activated, that this in turn, through many connections, can activate cytokines. And of course, cytokines, including IL-1, can activate the coagulation cascade. So coagulation and immunity are inextricably linked in the process of immunothrombosis, whose job it is to stop pathogens wandering around the body from the portal of entry. And just to say for you guys, thinking about the effect of viral hemorrhagic fever, is it directly activating the endothelium? Could there be infection, or is it a non-specific effect from the macrophages? We don't know. Obviously, I'm speaking to an Indian audience, and obviously I want to highlight this elephant endotheliotrophic herpes virus. So it's basically a virus that affects Asian elephants, and it specifically affects the endothelium. And here's a cytomegalic change in the endothelium. So this endotheliopathy can lead to a macrophage activation, DIC thrombosis phenotype, but it's no such thing compared to what we have been talking about in relationship to MAS and coronavirus infection, which is completely different from MAS. So I guess what I'm emphasizing here is you have to come down, identify your pathogen, and identify the primary cell type and the immunopathogenesis. So to finish up, Ram and I and Charlie, we said, well, the MAS phenotype is along an innate to adaptive spectrum, and it can be loss or gain of function. So for example, if you have an EBV infection of B cells, that's loss of function. It's B cell and it's adaptive immunity, and it can lead to a MAS phenotype, and we would treat that with rituximab to kill the lymphocytes. Alternatively, you could have an NLRCR4 gain of function. Again, I refer you to the last talk. Excellent, beautiful, sets the scene. Gain of function here in innate immunity is sole criterion that is sufficient to drive a MAS-like phenotype. So just to highlight, innate gain of function to adaptive loss of function, giving MAS phenotypes. And again, this is to highlight how there's many tissue-specific bases for giving a MAS phenotype. And I would highlight here that overactivation of the toll receptors, toll9 and lupus DNA may be sufficient to drive a type 1 interferon response that would be sufficient to drive a lupus MAS phenotype, but it's completely different. It's lupus, it's a different disease. And although it's a MAS-like phenotype here in Leeds, we just treat the lupus. We wouldn't worry so much about calling it MAS. We'd be very aggressive at treating lupus. And this is one of my last slides. It's just to highlight that if there is infection driving a MAS phenotype, and you guys know this better than me, in primary HLH, you treat the infection before you treat the MAS. Whereas if it's an adult or a SJA Stills phenotype, particularly if it's monophasic, that is not an immunodeficiency in my book, then you just come in and you target the MAS pathway, and you don't worry about infection. Well, of course, we usually use broad spectrum antibiotics for a few days in many cases. So to summarize, the COVID-19 SARS-CoV-2 pandemic is a newly defined viral pulmonary immunopathology. It's unique, it's different to MAS, which we've been seeing before. Immunothrombosis is a key feature, and most people don't go on to develop MAS of the ilk we see, but it can happen. And excessive immune responses definitely occur. The question is timing of therapy in those that have overcome the virus. There has been an incremental benefit of immunosuppression in SARS-CoV-2, many negative phase 3 studies. And what I've been trying to do is to set the scene for giving you guys a new way of thinking about viral hemorrhagic disease and hyperinflammation and the merits or otherwise of coming in with immunosuppression. So I'd like to acknowledge all of my colleagues, Charlie here in Leeds in particular, international people, including James O'Donnell, Anto Regan and Jim Meany, and Abdullah and Kazim in Israel, and also Ram, who's been working with us on these models. So with that, I am extremely grateful for you asking me, and I'm happy to hand back to central control and field any questions if you have them. Thank you very much for listening.
Thank you so much, Dennis. That was a brilliant talk. I think it explained almost anything that we wanted to know about COVID-19, and in fact, much more. It was so well illustrated, and your original work on it just so.
Thank you.
Yeah.
I think we lost him.
I think Dr. Chug, your voice is breaking up. I think we're unable to hear you.
And I'm sure everybody enjoyed it. So if there are any questions, Chandrika, maybe you can start fielding them.
I think there's just one question in the chat box, which says, so for COVID, so the question is, for COVID, we give vaccine to
great. So,
immunity
I'm
against
so sorry.
antigens.
If Chandrika can take the questions.
Sure, I'm doing that. Thank you.
Yeah. Can you ask a question again about the vaccine?
So the vaccine is used to induce immunity against viral antigens. So when a patient with COVID becomes critically ill with respect to respiratory compromise in the form of progressively worsening hypoxemia, we get very high levels of CRP, ferritin, IL-6, and D dimers. So the first line of treatment here is steroids and several immunomodulators, like we know, like tocilizumab and other MABs that have been used to suppress cytokine storm. So the question from Dr. Parag is, how does vaccination work to prevent serious manifestations of COVID versus a serious patient of COVID who needs immunomodulation? And why does vaccine not promote immunoreaction that could actually worsen the disease process?
Well, thank you. Lots of questions there. So first of all, the vaccine by priming adaptive immunity means that when the virus comes into the alveolus and people are vaccinated, they still pick up COVID, respiratory, they still transmit. And this is true for all vaccines that are systemically given. You get protection from severe pneumonia because of the adaptive immunities in a small area, so people will stop. It stops people getting it. So that's why that happens, but they protect the lungs when the virus is aspirated down. It replicates in the nose, and then it's aspirated down after a couple of days. So that's the vaccine issue. So I'm not sure, but in a patient like this, obviously, when they're sick in the wards, there would be no role for a vaccine. It wouldn't have time to work. This particular case. So what I'm saying here, if people are critically ill on ventilators in ICU, then there's not much evidence that the steroid or tocilizumab work. You need to get them when they are hypoxemic and requiring oxygen prior to ventilation. And that's when there is a definite benefit. But the benefit of adding the steroid is it's a bit of an absolute reduction of 4% in the positive studies. And in the negative studies from Brazil, the studies were stopped for futility. But I fully agree. The point I'm making is the virus is quickly cleared in some people. They have extensive non-viral immunothrombosis. So the steroids and tocilizumab help clear the thrombosed pulmonary vessels, and that allows the blood flow to go through, and then the people recover. So I think that's a specific mechanism of efficacy of immunosuppression, the borderline efficacy of immunosuppression in COVID-19 pneumonia. And what I'm saying is you could not extrapolate that to a viral hemorrhagic fever, which is a completely different mechanism of immunopathology and coagulopathy.
Thank you. And just one more question before we move on to the next session. What are your thoughts on the use of baricitinib in COVID-19?
Yeah, absolutely. So that's the largest randomized controlled blinded studies. They've done three studies and they were fully blinded, and they showed a clear benefit of baricitinib, including on people that were ventilated. And there's also a study from Brazil, which is smaller, on tofacitinib. So absolutely, in these patients who are not responding to steroid, and the baricitinib data showed efficacy both in people on steroids and those not on steroids. So at the population level, baricitinib said definitely has shown benefits. So steroids, tocilizumab, and baricitinib have the strongest evidence for efficacy. I was just making the point that in many of these critically ill patients, there is RNA, viral RNA in the blood, which means there could be viral replication, and the prognosis or the outcome might be better with immunosuppression if we could treat the people without active viral replication. And immunosuppressed patients can have viral replication for months. So say